Hello, I'm Kathy Stupansky, NAIOMT faculty, and now I'm going to demonstrate Level 3 inter-unit relationship example of a patient case that I actually currently have in the clinic right now. I'm only going to utilize more the lumbopelvic hip component of it. Keep in mind that the whole inter-unit incorporates the foot and ankle all the way up through the lumbar and thoracic spine that we would want to consider in looking at the total patient. But for this purpose, I'm going to demonstrate lower thoracic, lumbar, pelvis, hip. Okay, so this would be a patient. She comes in, she's a middle-aged female, gradual insidious onset of left hip pain, and she comes in and she had gone to her doctor and she has a script for trochanteric bursitis. This is a very common thing that their family primary care doctor will label it trochanteric bursitis. They've had an injection, it really didn't do any good for them, okay? So now they're in your clinic. They've also had some hip pain on the other side at times. So this patient is a little bit overweight, deciding to start get in a little bit of shape, starting to walk more and things, and starting to notice this hip pain increasing. Definitely over the trochanteric area, but not necessarily trochanteric bursitis. When you've gone through your lumbar scan from level 1 and into level 2, you found that there was really nothing positive on the lumbar scan, except perhaps a little PA pressure provocation positive over L5, and maybe some palpable tenderness over the left trochanter area, left gluteal and hip area there, and maybe what you saw to be a little bit of stiffness with active movement in the thoracic spine. Otherwise, the whole rest of the lumbar scan and lower quadrant scan appeared somewhat negative. No neurological signs or anything of that sort. So you feel confident to move into looking at the lower kinetic chain here. In your screening of the lower kinetic chain, you would have perhaps done a squat with the patient. You would have also perhaps done a climb test with the patient where you had them put one foot up onto a chair and lean forward, and that would have tested their flexion and their extension on the opposite side, and you would switch. That may have come up a little bit positive if they had a little restriction in that hip, which was then setting up facilitation into the lumbar spine. So that would be something that clued you into the hip as a possibility. When you looked at their trunk rotation in sitting in, go ahead and sit up here for a second, swing around here. As you had them cross their arms, they may have been a little stiff, even bilaterally going into rotation this way. So then that kind of clued you in, and as you looked at, they probably demonstrated some stiffness in this lower thoracic region, and you could go in and passive intervertebral motion test that to determine that they indeed were stiff in that area. Go ahead and lie on your back. You would also check their hip mobility on both sides, and I'll demonstrate on the right, and check for their rotation component, as well as flexion and extension, and more than likely their internal rotation more than their external rotation would be restricted on the side of the hip pain that you're having. So this patterning that we see, stiffness in the hip, stiffness in the lower thoracic, setting up an overuse or hypermobilization of the lumbar spine. So then the lumbar spine refers pain down into the hip, and thus trochanteric bursitis symptoms, if you will. But the true trochanteric bursitis would normally have some palpable swelling in the area, and typically some sort of a mechanism of injury that would have created trauma or some sort of chronic lying on that side that maybe caused them to develop that bursitis. So the fact that they really don't have those signs makes you think that this could be a somatic referred pain down into that hip. So with this type of a patient, my manual therapy that I would choose to do would incorporate some manipulation, perhaps of the lower thoracic spine, some mobilization to defacilitate the lumbar spine, some mobilization of the hip joint to then help to mobilize that hypomobile hip, and then in time, hopefully defacilitate the hip pain there. So to demonstrate the manual therapy techniques, come close to me here. And I'm going to just demonstrate a general extension manipulation of T9-10, very common to be stiff with this thing. The leg closest to me will be straight, the leg further away, just to give protection somewhat of the lumbar spine, will be bent. And then I'll have her roll a little bit towards me. I'll take my handhold here, come in onto T9-10, come up. And I like to have them kind of curl up towards me here. And then I come up over top and then rotate back, do a pre-manipulative hold. Are you okay with that? I'm going to deliver a little quick thrust through there. You might feel a pop. You okay with me doing that? And then I'm going to let you relax back, breathe in and breathe out, and then do a quick manipulation through there. Okay? And so then after manipulating that, then we can move on to the lumbar spine. So now I want to defacilitate the lumbar spine. That L5S1 created a positive provocation on PA pressure. If I'm suspecting a possible instability, then I would definitely do some stability testing. But a lot of times they aren't demonstrating any other signs of instability, so there wouldn't be a need, and especially since I'm not manipulating that segment, I'm probably okay to move on to a mobilization. So roll this way. I'm going to do a mobilization that would, not for increasing mobility, she's already moving a little bit too much, it's for neurophysiological pain relief from that area and decreased facilitation. So now I'm going to use a simple lock from below and a simple lock from above, and that creates a nice lever for me. So you're going to come close to me with your body here. Okay, so what I want to do is I'm going to go ahead and lock her down. So we're saying L5S1 is the segment that's facilitated here. So I'm going to go ahead and do an ipsilateral extension lock from above. So I'll place her top arm up here. I'll grasp onto here. I'm going to only rotate her down to L4, not into L5S1. I want to keep that in neutral. Then I'm going to change my palpating hand. And now I'm going to do a flexion from below, a little bit of flexion there, because that kind of tightens down that system. And then a same ipsilateral lock from below, so rotate towards me, and then straighten your bottom leg there. Just that far, because I don't want her to go too far into it. Maybe a little further, because what I can do with this, if she overside bends, then I can have my hands here, and I can just lean, and that will unside bend that segment that I wanted in neutral, the L5S1. So I just lean, and then I can do some grade 1s and 2s to create some traction, segmental traction right through that to defacilitate that segment. I can hang out here for quite a while to help work with that, okay? So then after I've done that mobilization, then I'm going to roll her onto her back. And the last component of it would be to mobilize this hip. Now I'm going to have her go ahead and flip her head down there, which most patients, I would just move sides of the table. But for this purpose, now I'm going to do just the lateral distraction on her. The patient that I had in the clinic wasn't extremely hypomobile, so I didn't feel the need of a belt. But some patients, you'll want to use a belt around you to do your lateral distraction. So this, come a little closer to me here. There we go. Take this hip up, find kind of that part of the range that they feel a little freer in. And then you're just going to do lateral distraction through the hip. And you're going to do, again, your mobilizations, grade 3s and 4s, to try to encourage improvement of that, stretching on the capsule through there. And you can follow up with some little oscillations here to further mobilize that hip. Lateral distraction again. Oscillations. And that would be the manual therapy that I would perform on that patient. And then I recheck and then check their rotation of their hip again and see if I've gained any more rotation. And then I would also recheck their, go ahead and sit up here, their extension and rotation in the thoracic spine, which I think she's kind of one of these patients that I have. She's definitely moving better after mobilizing her. And then immediately following the recheck, I would then train the patient in their first steps of core stabilization.